Hey, y'all. Welcome back to the 1776 podcast. On this episode, we have on Dr. Annie John, who is an anesthesiologist. I keep butchering that word during the podcast, but just a fascinating conversation. I knew very little about anesthesia before this interview, and it is just fascinating. We got into the weeds on how it actually works and a lot about her profession. So we had a great time. I found it to be extremely interesting, and I hope you all as well. I want to say a quick shout out to our sponsor, Rambler Sparkling Water. They're a local water company that really does a lot for conservation and continues to put their money where their mouth is. So we are very happy to have them on board. Hope you all enjoy. I'm so used to calling you Annie, though. I feel like I need to be like Dr. John. Is that what everyone else calls you?
No, I actually tell people to call me Annie, even in the OR.
Really?
Yeah, I'm one of the few doctors that does that. A lot of doctors want Dr. Smith, I'm like Annie better.
Okay.
And all the nurses, they find it very weird, but I like Annie.
That's great.
Yeah.
So, I mean, anesthesia, I don't know how to pronounce it correctly, but anesthesia is anesthesia. Okay, there we go. I still butchered it, but like I said, I'm a college dropout. But
it's all right.
Break it down for me. I mean, I know that's basically putting people to sleep to do surgery on them, but like, what does that mean exactly? Like, how would you describe that?
Wow, I've never been asked that. So it's basically getting the patient prepared for surgery, getting their anxiety taken care of before talking to them prior to the operation about what is about to happen and what you're going to do. You're one of the doctors that, a patient doesn't really get to choose. You meet them the day of, and you better hope that they're, good at their job because you don't have a choice in who is your anesthesiologist.
I never realized that. So it's just assigned to you, basically.
Correct.
Oh, wow.
Yeah. So, I have some days I have 6 patients, some days I have 2. I do mostly heart anesthesia, and so heart anesthesia, surgery for your heart takes 4 to 5 hours. So in those days, I usually have like 2 patients, but you just talk to them, tell them what's, going to happen. And then you push a bunch of drugs through their IV, get them to sleep.
But what drugs are we talking about? Like, so what do you start with? Okay. Like, what's the first drug? Break it down.
We give you kind of like an Ativan through your IV to kind of help. This is just kind of general, right? If you were coming in and getting your appendix out or something. I'd give you an anti-anxiety medicine to shut you up because you would bother me and keep talking.
I probably would.
Yeah, so I would just give you that kind of as we're rolling back to the OR after I've talked to you and kind of described what's going to happen. And then we'll get to the OR, we'll put you on monitors. So the whole thing about anesthesia is you got to monitor the patient from beginning to end, right? From when they get into the operating room till when they're out.
And what are you monitoring? Just like heart rate, all those type of things?
Yeah, blood pressure, heart rate, and oxygenation.
Okay.
And temperature, blah, blah, blah. But, and then we'll get you on, you move over to the table. We put you on about those monitors I just talked about, and then we give you fentanyl usually. Fentanyl's something we use every single day.
And is that for pain, or what is that one for? Okay.
For pain, and it's gotten a really bad reputation, obviously, but through the IV, it's a really good drug that can treat pain really quickly. So,
but if you're putting them under, what is the pain for when they're asleep, and you're just like prepping the body for when they go under?
So even though you cannot feel pain when you're asleep because you're under anesthesia, your blood pressure can still fluctuate a whole lot, and you don't want, the surgeon to deal with a really high blood pressure because that means more bleeding for the surgeon and stuff like that. And then when you're waking the patient up, you're kind of playing catch up. Like if you're not treating the pain under anesthesia as you go, you're going to be you have to catch up with that when they wake up and push a lot when they're waking up. So you kind of just, so anyway, you push the drugs, get a big amount of drugs, fentanyl and a medicine called propofol, which I'm sure you guys are aware of, the Michael Jackson drug.
That's also for pain?
That's just to get you to sleep.
Okay.
That's a sedative, it gets you all the way to sleep. And then we paralyze you, actually. Usually, if you were getting an appendix. So we give you a muscle relaxant. And once we give you that, there's no turning back. I have to be breathing for you. You are not able to breathe on your own. So that's what the anesthesia's job is to intubate the patient after we give you that muscle relaxant. So that's probably the riskiest part of our job, is getting the breathing tube in the right place. There's different airways in the world. Bigger people are a little bit more difficult. Kids can be a little challenging. Anyway, getting the breathing tube in, and once that breathing tube is in, We attach you to our ventilator. We're breathing for you. And the gas of anesthesia keeps you asleep at that point.
Is the heart still pumping?
Yeah. Yes.
Okay. So what all does that actually freeze? Like it's freezing your lungs, like, and then but your heart isn't?
No, that's interesting. No, it does not. So your heart's always beating unless you're having a heart operation and then you go on the bypass machine. That's a whole different thing. But no, it's just your muscles, the heart muscle is not included in that, so it continues to beat. But yeah, we are breathing for you. And if we turn that ventilator off, then you would die.
So what's the time frame from through the IV giving the muscle relaxant to I have to breathe for you? Like, what's that window?
30 seconds.
Holy cow.
So is breathing tube through the nose or through the throat?
Through the throat.
Okay.
So like all those people who got intubated for COVID, all the breathing tubes you see in the ICU or whatever, we put those in. So
And
when
this is
COVID,
once they're under?
that's once they're under.
Will you scoot the mic over just a hair?
Yeah.
Sorry.
Hello.
Because I've had several surgeries and I don't ever remember a breathing tube.
You wouldn't remember it. So we do it when you're asleep, and usually it's out before you even wake up or as you're waking up. So people don't remember it. The only thing you may know is that like if your throat hurts.
I remember having
bit.
like a sore throat.
Yeah, that's from the breathing tube. So once the breathing tube is in, then you kind of coast, right? It's kind of like a pilot's job. Once you get the breathing tube in, you hook them up, the gas of anesthesia, you're breathing it in and out, and that keeps you asleep. That's the maintenance part of anesthesia. And like I said, I'll substitute, or not substitute, I'll give extra pain medication if your blood pressure goes up, down, your heart rate goes up and down. Like, for example, when the surgeon makes the incision, although you can't perceive pain, your body can, and so those vital signs will tell you, and so you give some more, medication. We do use ketamine in the operating room. We use a bunch of IV medications to just keep that blood pressure stable and to have you wake up that you're not mad at us, that you're in a bunch of pain. So there's a fine line in giving too much, too little. So, but you just kind of get the hang of it. At the end, we turn off the anesthesia gas, and we reverse the muscle paralytics, and that gas is gone within about 2 minutes.
So then what's the process like of you have a tube down their throat, you're breathing for them, you reverse it. How do you know when to pull the tube versus their lungs kicking back on?
I had to go to school for that for 5 years. So your CO2 builds up. There's just ways you get the patient back to breathing on their own. And you can tell by the vital signs, you can tell by the ventilator what it's doing. And then at a certain point, and then a lot of people like to make sure that the patient's actually like following a command before they pull that breathing tube out. There's different ways, but you watch the ventilator and what the patient does on their own. Usually you just let the CO2 build up, and then you'll start breathing on your own if your CO2 gets too high.
And so when does the patient start to remember, like in their own mind, be back into reality? Is the tube fully out and they're...
Yes.
Okay.
Yeah, the tube is usually fully out. Usually people start remembering in the recovery room, but it depends. Like people that drink a lot of alcohol or have a high tolerance for pain medication, people that are chronic pain abusers or abusers of narcotics, they'll wake up. It just kind of depends on your tolerance for drugs. And some people wake up right away and remember right away, and then other people take them like, God, I didn't remember anything for hours. So it just depends on the patient. I mean, every patient's different. So,
what is your process like before you go into surgery and you're getting to know the patient in the few minutes you have them? Are you asking these type of questions to try to prep yourself to what might come?
I just really want to know about their medical history, right? Mm-hmm. I just want to know about their heart, their lungs, most importantly, their heart and lungs, and then, other comorbidities are what we like to call it. But, do they have high blood pressure? Do they have diabetes? Do they have this? Do they that? So really, we're just trying to find out about their medical history to find out how they'll kind of behave for us in the OR. Do we have to check blood sugars? I mean, we have to take all of their medical history into consideration for the anesthetic.
What do you ask about the lungs other than if they're a smoker or not?
Well, there's a lot of other things that, do they have asthma? If you put a breathing tube in someone that has asthma, that could be pretty dangerous because your bronchioles and everything could tighten up, because that's like an asthmatic what happens. So, I don't know, people have had Agent Orange. I mean, stuff that you just never hear of. But if their lungs, it makes it more difficult for the patient to be reversed and to breathe on their own.
Gotcha.
After we've given them that paralytic. So you're taking all that into consideration. But at the end of it, it's kind of the same spiel over and over again. Yeah. And you just want to make them feel comfortable, right? You kind of want to have some bedside manner in the whole thing, because otherwise it doesn't make the patient reassured that you're.
Just give them a little extra dose of the Valium or whatever.
Yeah, we do. I do. I love doing that, and I would do that for you.
Okay, thank you. I appreciate that. So I don't just keep talking. But
Right.
so if someone did have asthma, how would that change what you're doing, or is it just something you're just more aware of a possible negative outcome?
It just depends on how bad the asthma is, really. Like sometimes I'll be like, "Oh, can you take your inhaler before we go off to sleep, just so your
Okay.
lungs are nice and wide open." You know, it's different if someone uses an inhaler once every month versus someone that uses an inhaler 3 times a day for a rescue. And so you just kind of you talk to them.
Mm-hmm.
That's the biggest thing, is you just get to know their medical history, and if there are different things you can do for an asthmatic. Sometimes you can take that breathing tube out when the patient's still asleep breathing on their own, because if you wake up an asthmatic with the breathing tube still in, they're not going to the lungs aren't going to like it. They're going to want to constrict down, and you're going to start wheezing and all that stuff. So sometimes you take that breathing tube out, which is a little bit riskier when the patient's breathing on their own still asleep, so that does not happen to their lungs. So, but like I said, this took so many years to learn, because anesthesia is sort of, it's, you don't really learn about it in medical school. You don't ever take an anesthesia class. You only learn about physiology of the body, really. You don't ever learn about, so anesthesia is something you kind of have to pick as an elective and go see if you like to do it, because no one teaches you about anesthesia. So the first day I was in my residency of anesthesia, it was very kind of new, because the anesthesia machine is not something you learn about. The drugs of anesthesia, or, the gases, it's kind of its own little entity.
So what was your process? You went to med school. I mean, just break it down. What was your story going through it all?
Well, it's a great question. I didn't always want to be a doctor. I mean, I still don't know if I want to be a doctor. It was something that I had really good grades. I was good at academics. I was in biochem. I was a biochem major.
Where were you going to school?
Started at Trinity University.
Yeah,
and
San
then,
Antonio?
Yeah, and then I hated it there. I can go into that later. But then I finished at Texas Tech.
Okay, we won't hold that against you.
Right, I know. It's okay. Where'd you go to college?
I dropped out.
Right.
Shots fired.
And then I went to medical school. So I didn't know I wanted to be a doctor. And I was like, I have these good grades, whatever. I worked in a lab sequencing DNA.
That sounds terribly
It was
boring.
terrible. And I listened to music all day and downloaded all this music onto anyway, I got in a huge amount of trouble for that. But
For downloading the music or listening to it all
because
day?
like back in the day, it just clogged up the whole computer, and I got in trouble. Anyway, that was really boring. So I thought maybe I'd just apply to medical school and see if I could get in. And I was kind of at the right place at the right time, because the guy that I was doing research for in the DNA sequencing lab was up for the Nobel Prize. So
Oh, wow.
I think it was a good place to be, and I think that recommendation really helped me. I don't know what if I would have gotten in without it, to be honest with you. But I had really good grades, had a decent MCAT, which is the test that you have to take to get in, and then I had a really good recommendation from him. So then I ended up going to Galveston for medical school. Then I did residency in anesthesia in Dallas at Southwestern.
Okay.
Yeah.
So how did you decide at that point, though, to choose to go into that? I mean, what was it that sparked your interest?
I don't know. I all my girlfriends were doing it for, quote, lifestyle, because you didn't have to, I don't know, it has a better lifestyle, and you make a decent amount of money as an anesthesiologist.
Yeah.
I think that's.
I've always heard that before.
Yeah, I mean, it's a pretty, but everyone thinks it's a little bit better than it is, because you have to take a lot of call. I mean, there's people having surgery all the time. There are women needing epidurals all the time. If people have heart attacks all the time, they need to be fixed. So you don't really realize how much you're going to be on call at that point. But all my girlfriends were like, let's do anesthesia. And I'm like, okay. Funny enough, after you're in medical school, you kind of have to decide what you want to do. I loved surgery, but surgery takes, it's tough on a female to go into surgery. There's a lot of hours, there's a lot of it's a male-dominated specialty. And so I actually interviewed for both surgery and anesthesia. And, when you're in medical school, it's called match day. You get an envelope. And so you basically go to all these places to interview. I went to New York, I went to Texas, I went to all these places, and I interviewed for both surgery and anesthesia. Most people know what they want to do. They interview for surgery, they go to 8 places, whatever. So on match day, you go up on the stage and get your envelope and open it in front of the whole medical school class. And it shows you where you're going to go. And so I didn't know where I was going to go or what I was going to be when I grew up. So I got anesthesia in Dallas. So that's how I ended up in anesthesia. I'm like, okay. So
You just went with it.
I went with it. And I'm glad. I mean, I guess I'm glad it happened like that.
What'd you really want to do?
Well, that's funny that you say that, Matthew, because I went into anesthesia and I didn't love anesthesia. Didn't love it. Didn't find it that stimulating. I felt like you were always at the beck and call of the surgeon. Surgeons didn't respect you as much as I wanted them to respect me. So at my 4th year of residency, I got to come to Austin and be on the Dudley and Bob radio show. I don't know if you guys know who that, but Dudley and Bob, yeah. So I got to be on that, and they thought I was really good at it. So I thought, I really want to be on the radio. So this is not a joke. I went to my chairman of anesthesia, and I told him, this is on my 4th year. I think I had like 8 months of anesthesia school left.
Say, it's a 5-year program, or is it?
Well, it's a 4-year, but that's the whole of it. It's only 4. But I was in my 4th year. I did a 5th year later to concentrate on hearts only, but that's a different story. But I went to him and I said, I just don't like this. This is not for me. I think I want to try to be on the radio. This is after, I think, 2 episodes of the Dudley and Bob show, and I thought, this is what I want to do. I quit medical school to try to be on the radio.
So you fully left medical school?
I did, yeah.
Holy cow.
I did. I did a lot of stuff to figure out how to, basically in radio, like back in the day radio when I wanted to be on it, it was Kid Craddock. Do you remember Kid Craddock in the morning? Yeah. So I tried, he was looking for a girl. I was kind of auditioning for that. It was kind of like you had to be in the right place at the right time, though, or you had to be an intern and make no money. But yeah, it was a whole thing. I told my parents I dropped out of medical school to try to be on the radio.
What'd they say?
What did she say? My mom was very supportive. My dad was just like, are you kidding me? Clearly it didn't work out. I'm an anesthesiologist, but I did have to graduate late. So that being said, I graduated, and the next year kind of fell into places for me. There was an extra spot for a cardiac fellowship, which I didn't even like anesthesia. I don't know why I was going to go do cardiac for a year, because I just didn't know what I was going to do, because I thought I was going to be on the radio.
So how long were you out of school with this radio stint?
Months.
Holy cow.
Yeah, months. And so then it just worked out that they allowed me to graduate with my class, but I had to stay and take extra classes after they left. So, but yeah, so then this fellowship spot opened up, and fellowship is like if you want to continue working in anesthesia or being very specialized in anesthesia, you do an extra year, like of pediatrics or hearts. And so, anyway, there was a vacancy in one of those spots, and they asked me to do it. I'm like, I don't even like anesthesia, but I did it, and it was the best thing that's ever happened, because cardiac anesthesia is kind of different than other forms of anesthesia, because it's really kind of high stress, kind of like the surgeon really needs you.
Yeah, so break that down. What's different about it? During the surgery, I know you said once you get them under, you're kind of on autopilot more or less, looking at things. But with heart surgeries, is that different? Is there more to pay attention to?
Yes.
How specifically?
Patients are sicker. They're just, it's just a different, you're in constant communication with the surgeon. I do an ultrasound of the heart during the procedure, which images all the, that's the biggest thing that we can do that a general anesthesiologist can't do. I image the heart, and it's an ultrasound that I put into your stomach, and I can look and, like, for example, if you need a valve surgery done or something like that, I can look at the heart before the valve operation and after the valve operation and tell the surgeon, hey, this part looks a little, like you might need to put another stitch in here. I'm making it very general for you guys. But So they need you. You know what I mean? Whereas sometimes in general anesthesia, you just kind of feel like you just put them to sleep and you sit there for a few hours. So anyway, I liked that feeling of it, and and I still love doing hearts. So that's my.
When you do the ultrasound, you said you go through the stomach. Like, what does that mean? I mean, how are you like? What does that process look like?
You put you ever heard an endoscopy, like when you get an upper endoscopy or a colonoscopy?
Go on the other end.
Right. It's the same thing. It's like this. It's like a tube that goes into your mouth, into your esophagus, and into the stomach.
Okay.
And your esophagus and your stomach is really close to the heart. So it's just basically a way to ultrasound image the heart. And you're asleep when this happens. So it's just something extra that we can do. And I have to get certified in that to look at the heart under anesthesia,
Okay.
I guess. Yeah.
So when you go into like a typical day of surgeries, and are you working with a lot of the same doctors? Like, are you building rapport with them? Are there some surgeons that I'm sure you're like, oh, rolling your eyes, got to work with this guy today? Or
Yeah.
I'm sure you have some of your favorite surgeons. I
Yeah.
mean, what's that like? How much does it vary for you?
A lot.
Okay.
I mean, it's a lot. And mostly in Austin, people are pretty nice. But, there's always the few that throw instruments or get mad or are mean to nurses or
Throw instruments, like throw stuff in the procedure room.
I've had a few.
Little temper
surgeons-
tantrum?
Oh, yeah.
Holy cow.
They are very, if it doesn't go their way, surgeons can be very malignant. But here in Austin, I found, in Dallas, they were worse. But here, I mean, even the heart surgeons here are phenomenal. There's one heart surgeon group here in Austin, and I get to work with them. And I can't say there's a bad one in the bunch. I don't mind working with any of them. But if you go to different cities, I bet you it's not the same. And then general surgeons, very hit or miss. I mean, when you think about it, there's, I don't know, hundreds of surgeons here. There's going to be a few that are difficult to work with.
Yeah. I'm sure people are curious and answer what you feel comfortable with, but who is that group of heart surgeons that you like?
Oh, it's just the cardiothoracic. What are they called? Well, I don't even know the name of it. They're the ones at the Heart Hospital of Austin.
Okay.
They're based out of that.
Dr. Roach?
Dr. Roach is a cardiologist. I know How do you know Dr. Roach?
I grew up with his kids, and he did my dad's triple bypass, I think.
Yeah,
Or
he does it.
just
He's the cardiologist,
Okay.
so he probably referred him to the surgeon to get it done. But Paul Roach and he knows, you can say, you know me, but I know, yeah, he's great. He's hilarious. As a matter of fact, my husband's dad needed a very big operation, double valve surgery, which is, one of the biggest we do. He lives in New Braunfels and wanted to get it done there, and I brought him here just because, I know the guys. They're great surgeons. We're really fortunate to have a really good surgical team in Austin and cardiologists, I feel like, because I don't know, I can just tell they're really good, and we don't have people coming back to the opera a lot. If you think about when you're operating on a heart, a lot of times there can be a lot of bleeding afterwards, like just little micro, things bleeding or whatever. So back in Dallas, we used to have to bring people back to the OR a lot for bleeding. Rarely happens here.
And I guess you would know about all that because you're having to put them back under to
Correct.
fix what's going on.
Correct. Yeah. So great guys.
So Austin is the spot if you need heart surgery.
Yeah. If you go to Mayo or something, if you go to a bigger place like that, but I think these guys are almost on par with them. And it's just not as big of a, operation as going to Mayo. And there's certain things that Mayo is good at or whatever. But
What is Mayo?
Mayo Clinic, that's just kind of like where people go to get surgery. It's in the Cleveland Clinic, all those. It's just different hospitals around the nation might be better at, a certain surgery. But all in all, Austin's a really good place to have surgery. But I hope that you guys aren't going to have heart surgery anytime soon.
I hope not.
I know.
I have to get my deviated septum done here before long.
You've said that for 4 years.
I know, and I finally went to the doctor on it. He said it was one of the worst he's ever seen, and that my right side is like 5% or less airflow.
Wow.
So it's time. So can I request you to be my anesthesiologist for that?
You would drive me crazy.
She's going to deny you.
No, it depends on if I have privileges on where you work. So it's basically,
Okay.
I don't know who your surgeon is or where you're going to have surgery, but you could.
Well, I don't want to get stuck with some, random person that's going to show up and drug me in 5 minutes. I guess
No.
you're going to do the same thing. But.
Well, it's kind of weird with anesthesia requests, right? Like, you don't tend to do I don't know if I'd want to do you.
Okay.
Just because, I don't know, I know you pretty well. Like, I definitely didn't do my father-in-law.
Okay. It's almost too close for you to know the person.
Yeah. I mean, there's certain, no, I probably would do you, I guess. But there's certain, like, I don't know, if something goes wrong, you would feel terrible about it. So some people, anesthesiologists, are like, no, I don't do requests. Just because if something went bad, you'd feel terrible. But I could get you a good anesthesiologist.
I feel the same way with home building. Sometimes if it's too close for comfort, I'm like, I don't know if I want to build to your house.
Right.
If I know them too well.
Right, I know. We didn't know each other till during the process.
Yep.
Would you build a house for me again?
I don't know. Depends if you're going to do
What?
anesthesia. Put me under or not. I keep messing up that word. Grammar's not my best.
Yeah, it's a hard word to say, but yeah.
So who do you technically work for? I mean, you work for, you go around all across Austin, it sounds like, doing a bunch of different surgeries, but who do you work? How does that work exactly? I mean, who calls you? Do you have a pager? I mean, does a bat phone go off? I mean, how does that work?
Bat phone. So I'm different than a lot of people. So medicine is becoming kind of like a corporate nightmare, to be honest, in my opinion. We used to be kind of a mom and pop group that was like the St. David's group of anesthesia. There was a St. David's and a Seton group, and you were part owners of the group, and you bought into the group as an anesthesiologist, and you had ownership in the group and all this stuff. But now, not only anesthesia, but all these groups, whether you're an ear, nose, and throat doctor, whether you're, are getting bought by these corporations. So we got bought many years ago by a big corporation, and then since then, I think we've been bought by they just keep passing people to the next corporation, and then you just you're working for the man, right? And so it's harder to hire people. You're working harder for less money. You're doing all these things. So I actually was in a very fortunate situation. I didn't have to work as hard as I didn't have to work the 60 hours a week that my partners were working. So over the years, I've kind of cut back, and I was like a 75% employee or whatever. And then recently I did I just do PRN. So I do as needed anesthesia, and I really just get paid by the hour. I don't have to work for anyone. I have no benefits or anything, but I have to pay for my own benefits. But it really rid me of just the grind of being on call all the time, of work, going to 18 different facilities or whatever. And it's nothing having to do really wrong with the group per se. It's just the way that's going, medicine is going. And I was fortunate enough that I'm able to now do my own thing. So I go kind of here and there, and they always need extra help. So if I can work 5 days a week, 6 days a week, or I can work 2.
So how does that work? Do you have a thing you log into and you see the surgeries and you pick the ones you want?
Well, I have kind of my hospitals that I like, and I say, hey, I have this day available, and they always usually scoop me up because there's always anesthesia right now is very short across the board in the nation. So pay is good. So I can really just kind of tell people, hey, I can work these days, and they usually use me.
Oh, wow, that's awesome.
Yeah, so it's very nice.
How much do the hospitals vary as far as when you show up? Is all the equipment relatively the same, or are some hospitals like working on 30-year-old equipment and you don't like going to it? Or, I mean, how much does that vary?
They're really kind of on the same. I mean, there's really 2 basic anesthesia machines, and them. I mean, some of them are older than the others, but it's not terribly different.
Okay.
I mean, the drawers are different. You can't find stuff. But, I mean, it doesn't bother me having to go to places that I really don't know. There's a big movement in the world of doctoring called locums. And locums is where you go to a place, whether it's, Beaumont, Texas, or wherever, Detroit, and if they're really short in doctors, they say, we'll pay you a whole lot of money. We'll pay for your housing. We'll pay for this, that, and the other if you just go do anesthesia there for a month. And so you cover them when they're short, and a lot of people are doing that now. So there's a lot of traveling doctors going around because the money's really good, and you can work for about half the time and make what you're making as a full-time employee.
Oh, wow.
Yeah.
I'd be going to Hawaii or somewhere fun doing that.
Well, I know, but you're you don't have a family yet.
Yeah, that's true.
So that's harder for people to have families.
So these days, are you mainly around Austin, or are you going San Antonio?
I go to New Braunfels, San Antonio, but Austin. I mean, I could work every day in Austin, if I wanted to. But like I said, I take some days off here and there to be with you guys. See?
Thank you. Much appreciated.
Yeah. So
Someone's out there dying, like, where's Annie?
No.
And, she's here.
There's enough of people out there. That's the beauty about anesthesia. I mean, you can just substitute for people. It's not like a doctor where if you would want to go see Dr. Smith, you only know Dr. Smith. But anesthesia is good because a lot of people can do the same thing that I can do.
What's the percent, if there is one, off the top of your head, of people who die during that? Because I've heard sometimes, loaded question, that on like routine surgeries, I've heard that like going under can be the most dangerous part of it. Is that true?
Yeah, it could probably be. It could be true. It just totally depends on your comorbidities and like what you have going into it, right? I, knock on wood, have never had that's not a heart patient, like an open heart chest. I have never had somebody die in the operating room, unless it was like a gunshot wound or something like that.
Yeah, they bled out or something.
Like that they were almost, in trauma, you get these gunshot wounds or whatever. But usually you can get the patient out of the operating room. You can usually give them a ton of blood and the products that they need or whatever and get them up to the ICU. But I've never, it's rare that a normal, healthy person will die under anesthesia.
Okay.
It happens, though, because I know quite a few people it's happened to, but very rare. Now, hearts, I think, if it's your first time operations, maybe a 1% chance that you die from the time you go to the OR till the 2 weeks afterwards. So, but in the OR, rare. Even for a heart surgery, it's rare.
So does the hospital assume that liability and risk with like insurance purposes, or do you individually as the anesthesiologist?
You individually as the anesthesiologist. So I have to pay for malpractice insurance. When I was with that other group, they would pay for that. When you're with a big corporate group, they'll pay for all those benefits in your malpractice, which is high. I mean, it's a lot of money to pay for, thousands and thousands of dollars a year just to, have malpractice for anesthesia. OB-GYN's really high too for malpractice. But so now I have to pay for that on my own.
Gotcha.
Yeah.
Is there like a 3-strike limit on that? Or I mean, if you're a doctor, could you keep killing people and you just pay more in insurance? Or is there like a certain point when they're like, maybe you should stop?
I don't know that. I've never, knock on wood, never been sued, but I know plenty of people that have been sued.
Okay.
For sure. I mean, this is not uncommon. I just think that I'm lucky. Not that things haven't gone wrong or whatever, but some people tend to sue and some people don't. But
we're also probably pretty good at your job, it sounds like.
Yeah,
so.
But even if you're good, people, patients can be kind of crazy and want to get stuff out of you that, I don't know.
What do they sue you for if someone did not die? Do they have side effects or?
Okay, I'll give you an example. You give a drug through, this happened to one of my friends. You give a drug through a vein and it gives someone really bad phlebitis, like inflammation of the vein, and then your arm gets infected and all this stuff. And they're just complications that would occur with stuff you would probably do anyway. So that's why it's really hard to sue a doctor and win. Because when you sign all your consents to go to sleep and when you sign your surgical consents, you're signing a lot that you don't even realize that you're signing. But, patients will try to sue for,
They'll sue for anything nowadays.
They'll sue for anything. And, sometimes it's negligent on the doctor's part, and they can prove that. But oftentimes it is not the case. And it's really hard to sue a doctor and win. The doctor's almost always going to be able to practice again. Like Michael Jackson's doctor. I don't know about that. But, But you have to pay quite a bit in malpractice.
Interesting. Mm-hmm. What would be your worst case scenario patient? I mean, someone comes in, they're 95 years old, they smoke 3 packs a day, they have asthma, and they drink like a mule. I mean,
I don't care about that. I just care about if I can intubate them.
Okay.
So
what's your worst case scenario? Come rolling in. What's the one that you're most nervous for?
A big, huge, overweight dude that can't move his neck.
Okay.
I had a patient one time that. So once we push that muscle relaxant, we ventilate. We put a little mask on. We put a mask on, and we are, we're getting the bag. What is the word I'm trying to say? Squishing the bag ventilating for you before we put that breathing tube in. I had a patient that was a large guy, not that big, but large. And your biggest fear is cannot ventilate, cannot intubate. So when you're ventilating the patient, squishing the bag, you usually can do that with everyone. You're able to move some sort of air. Even if you can't get the breathing tube in, you're at least able to move some sort of air by squeezing the bag. But if you get into a scenario where you've pushed the muscle relaxer and you cannot ventilate, then it becomes a huge emergency. They may have to do what's called a cricothyrotomy and put a breathing tube through your neck. So anyway, I had this patient, could not ventilate him. And so I looked in there and there was I was like, why can't I ventilate this guy? There was a huge tumor in his airway that nobody knew about.
Holy cow.
Yeah, so that was just a scenario which, that kind of stuff, that's when you freeze and think, oh my God, what am I going to do if I can't ventilate? Long story short is I was able to get it, but it was it was not smooth at all.
Is there not any sort of scoping of the throat or looking before you get to that point?
Because usually it's normal.
Yeah,
I mean, that was once in my whole career that's, happened. I mean, you have difficult airways for sure, but the only time I've ever had a do not ventilate, cannot ventilate, cannot intubate was that person. So
how many people have you put under, you think?
Jeez, thousands and thousands.
Really?
Mm-hmm. Thousands and thousands. 5,000? I have
Holy
no
cow.
idea. A lot.
What's your favorite? Is there a favorite surgery? Or is there one that you see and you're like, oh, I want to do that one?
Matthew, not anymore.
No?
Sort of over. I guess a valve surgery would be good because I like to do imaging. But I mean, the end of it is it's a job. You go and it becomes just a job. But anesthesia is cool. I mean, I'm not going to lie. It's a cool specialty. You get to shut people up, putting them to sleep. The drug, I mean, the magic of drugs is insane. Women that you put epidurals in, they love you because you make them feel better. Patients, they pretty much like you because you're pushing drugs on them. So it's a but you're not.
It sounds like what I'm gathering is your favorite part of the whole thing is drugging people.
That's right.
Okay, cool. Just making sure we're on the same page.
Yeah, it's always pretty fun.
You gotten to drug any famous people?
I have.
You allowed to?
I'm not allowed. I'm not allowed. But I've done a few of them, actually. We have a big group here that does, I don't know if you guys know what atrial fibrillation is.
Yep.
I've heard the term, but I couldn't tell you what it means.
It's like when your heart doesn't pump effectively or your atrium and your ventricle aren't pumping correctly. And so it's an electrical problem with your heart. And so anyway, we have one of the biggest groups probably in the world here in Austin at St. David. So people come from all over the world and who have AFib to get it fixed. And there's this one guy that everyone comes to because he started the procedure to fix AFib. He's from Italy, so they come to see him and his partners. So we get a lot of people in there.
Interesting.
Yeah, that are pretty famous.
I don't know if it's true, but I've heard that there's a small percent of people that when they go under, they don't actually go under, and even though they're under, but they can still feel pain. Is that true?
Yeah, unfortunately, it's gotten anesthesia gets a bad reputation because of that. The only way you're going to feel pain under anesthesia, if you're under general with a breathing tube, is if there's not gas and the gas machine's giving you the gas. And that's pretty much on the anesthesiologist to make sure that they're full or whatever. But what people are mostly talking about is when they're under twilight anesthesia, like when they get a colonoscopy or something and they're using those medicines that just make you forget and kind of like off in the twilight zone. Some people remember things like that because, again, different people have different tolerances or whatever, but it's not uncommon to remember something if you're getting, quote, like twilight anesthesia.
So with that being said, you're not freezing their muscles and operating their lungs in that type
Correct.
of?
Correct. Like a colonoscopy, for example. You don't need to be intubated for that. So there's different ways you can do anesthesia for a colonoscopy, but back in the day, they would just give you like some, like kind of like the liquid Ativan I was taught, or like the Ativan, it's called Versed, and some fentanyl, and most people would not remember it, but you're still kind of awake and aware of what's going on. They just forget. They have amnesia with it. But so people always say, "Oh, I remember some of my colonoscopy," and they think they have awareness, but it's different because they weren't under general anesthesia. Does that make sense?
How many different types are there?
Lots.
I had no idea.
Yeah, there's lots. Not lots, but like 5.
Okay.
Because then there's another anesthesia. You can like have an epidural or a spinal where you're numb from here down. So if you needed like a knee scope or a knee surgery, you could get it done with just that. But
interesting.
Usually people want to be asleep. They don't want to hear what's going on. So,
yeah.
Usually there's people like me that had her knee scoped, and I wanted to be completely awake because I didn't want anybody to talk bad about me. So I asked the surgeon, Dr. Ellens, I said, please, can we do it under like a spinal? And he's like, no. He said, you would drive me crazy. So we're putting you to sleep like everyone else.
What is a nerve block? Does that have anything to do with anesthesia?
It does. Yeah, we do nerve blocks all the time. So like if you were to get a knee surgery or a shoulder surgery, we do a nerve block that would make your shoulder numb. And it's
That's
mostly...
what I had. I had a shoulder rebuilt, and I had a nerve block. And I think it was probably 6 hours after I got home.
Yeah.
My throat started feeling like it was closing up, and I couldn't breathe, and I couldn't really talk.
Yep.
And apparently the nerve block had gotten over to my throat muscles and made them numb.
Yep.
And so I was fine and could breathe, but mentally I thought it was closing up.
Yep, that happens. And usually we kind of tell people that is how...
They did not give us a warning at all.
I bet you that's kind of scary. And your diaphragm probably was paralyzed on that left side too. So it can, we look with... Do they look with ultrasound? Do you remember getting the block? Because usually we sedate.
I remember being at home in an armchair, and I tried to call out to my mom, and I couldn't talk, and so I ran to that side of the house, and I was not in good shape, and so I was hobbling like,
yeah,
we got to go, and they freaked out because they thought I was choking on food.
Right.
And,
well, what did you go to the hospital?
We started driving there, and by the time we got there, it started wearing off.
Oh, really?
Yep.
Okay.
I mean, it was like 5-minute drive to the hospital.
Yeah. Well, that's weird. Usually it, lasts a little bit longer than that, but we usually tell people if we do a shoulder, hey, if you feel like you can't take a big deep breath, it's because your diaphragm, all those nerves right there, the ones that supply, your trachea, vocal cords, all that stuff, it's right here. So if it if it migrates at all, it can get your diaphragm. So people kind of stress out about it.
I went to full panic mode.
Yeah,
I thought I was about to die.
Yeah, they probably should have told you that these are.
No, we were running red lights. About drove through the hospital doors.
Really?
They were like, "Calm down."
And then it wore off.
It did. I mean, I was able to breathe the whole time, but it sure felt like it was closing the whole time.
Yeah. No, I bet you that was scary.
So how do you do nerve block? Is that just a shot? Like going to the dentist and they numb you up?
Exactly. But it's basically you look with all of your nerves that supply like your arm, for example, are up here in your neck. So like your shoulder. So we just look for the nerve with the ultrasound, and we stick a needle right near the nerve bundle, and it basically numbs that whole nerve bundle. So like you wake up from anesthesia with a numb arm, which is great, right? Because you have no pain after the surgery. But then after the nerve block wears off, then you do have the pain.
I remember when it wore off,
Yeah.
I was like, oh my God, I got shot in the arm.
Right. I know. You're living the good life when you wake up from anesthesia, but then it gets bad after that. So, but it's great because, your blood pressure doesn't go up during the procedure, so there's less blood loss and all that stuff. For the surgeon, it's really good too. So, and the patient. So we do them a lot. But sorry, someone didn't tell you that. If you would, now you can have my personal contact information. Just call me directly when things like that happen.
I'm not allowed to. She doesn't want to operate on me. But
I'll get you someone good.
Okay.
I'll get you someone really.
Make sure you never wake up.
Yeah.
Yeah.
Drug me up real good.
I know.
Oh,
I'll videotape you. Mm-hmm.
I don't know why I've been nervous about getting my nose done. When they told me it's 5 days of mouth breathing, I don't know why that makes me anxious. I like being able to breathe out of my nose.
Yeah, that is kind of. Well, they're probably going to pack it in there. They're going to pack something in there.
Yeah,
Yeah.
I'm not looking forward to it. That's why I've been talking to you for years about it, because I keep knowing I need to do it and keep not doing it.
And you've also had like a back problem, right?
Yeah, that's been better. I've been
Okay.
strength training, and it's helped it. But yeah, I've got
Yeah.
neck, spine issues.
Yeah. Okay.
Good memory.
Yeah. No, I know. A lot of people come to doctors with doctor questions.
That's very true. Yeah, I remember I always text you with stuff like, what do I do with this?
I know. I'm like, just go to the doctor, dude.
Yeah, quit texting me.
Just go to the doctor. Yeah, you get that a lot as a doctor.
Yeah.
Lots of questions, lots of which is fine. But
Same way with houses. I get all the house questions.
Right.
Oh, yeah.
I feel like my parents were, when I went to med school, I mean, granted, they were so proud or whatever. This is my daughter. She's a doctor. I'm like, ugh. I'm like, I'm Annie. I'm not a doctor. It got me so mad. I know. They're going to listen to this podcast too.
Good.
You heard it, Dad. I'm mad about that. You can stop doing that.
It's not too late for you to chase your radio dreams. I mean, I guess
well, I'm
these
on the
days,
radio with you guys
that's
right
what
now.
I mean. You start your own podcast and live your dreams.
I know. I just don't know how to do it. I guess I could just do it with my phone, huh? Nobody would listen.
It's not that complicated.
Yeah, I really.
I'll be a producer. I'll take 20%,
Yeah.
and we're good.
Do you guys know Deb from the morning show?
Mm-hmm.
So I met with her. We toyed with doing something, but she's way cooler than I am. But anyway, Deb, if you're listening, we could totally do a radio show. I mean, this doctor thing can only last so long. The one good thing about being a doctor is you'll always have a job.
Yeah.
You know,
Sounds like you're in high demand right now.
I guess so. And being a doctor as a female it's hard. I mean, maybe people are going to say otherwise, but you're dealing with type A personalities and you go to medical school or whatever. I didn't date. I didn't do anything back in, all I was doing was really focusing on school. I didn't get married till I was 44, 45. It's a hard gig as a female. I mean, you don't start making money until you're 32, 33 years old. So by the time I got married, I didn't ever want kids, but thank God. Because, everything's a little bit later in life that you start doing and you experience things a little bit later. At least it was for me.
Just the time commitment, how much it took to do it.
Yeah. And I wasn't, I guess I'm a smart person, but I had to work really hard to get where I am. Some people it just comes naturally too. That's not me, so a lot of physicians are really smart, maybe not as bedside manner or I don't know, maybe it was not as difficult for them as it was for me, but I really had to study really hard, put everything into it. I mean, when you do a residency, you're working, 70, 80 hours a week. You don't have time. Mm-hmm. So you miss out on a lot. So being a doctor is great in a lot of ways, but it's tough,
mm-hmm.
Especially as a female, and get a lot of students that come and ask me things like, would you do it again? Would you do it again? I don't know.
Yeah.
I don't know. I'm not sure. I'm not sure actually. I'd definitely take a radio job.
Yeah, so looking back, do you think you would have wished you would have left the radio and chased that?
I mean, everything happens for a reason, right? But I also was on the Bobby Bones show.
Oh, were you really?
Uh-huh. Yeah.
I'll have to go back and find those episodes.
Well, that one was, I think I just was maybe he just let me come in and listen to him. I don't think I was actually on that one. The other ones I was on, talked a bunch.
Very cool.
Yeah, I know. So anyway, how's this podcast doing, guys?
We're doing good.
1776?
Yeah.
Well, you're going to get a lot of listeners from me.
Oh, yeah. Looking forward to it.
Yeah.
Finally going to blow up.
I know, exactly.
So what have we missed on the Annie John story? You like drugging people. You should have been a DJ radio host. Mm-hmm. What else?
I have an awesome husband that Matthew knows well. He's in advertising and marketing. You guys are going to have him on. He's
Let's
a really weird guy. Started Grumpy Cat.
We'd love to have him on.
Yeah. And
You started Grumpy Cat?
You remember the memes and all that?
I do.
Yeah. So he was working for Frisky. So needless to say, we're very different. I'm type A and he is type B to the max. But works out and it works. And so we have an awesome little life in Barton Creek. We go travel. I travel all over the world to watch sports. We do that together. We just got a dog.
Y'all did?
My life is boring.
What kind of dogs y'all
It's
get?
the cutest dog I've ever seen.
Yeah.
Her name is Birdie. It's a Morkie. You're gonna have to meet it one day. But so yeah, my life is not about anesthesia. It's just about good life.
Kind of feels like you're kind of over it at this point a little bit.
I mean, kind of over it. No, it's still fun to do, but it's just it's a cool thing. It's a really cool I mean, anesthesia is just cool when you think about it. I mean, you lose time, and it's just a cool idea. And how they invented anesthesia is crazy.
Yeah, I was curious. How much do you know about the history of it? I mean, who was the first guy to be like, I think I can put someone to sleep and
You're
cut them
asking
open?
me stuff that I don't remember. I mean, ether. Remember ether? Or do you know what ether is?
Oh, yeah, that's the that was like the very old school way of yes.
The anesthesia gas. They'd like put it on a cloth and people
real
would pass
flammable?
out. Yeah. And people would get really, really sick with it. But it was patients have had it that are alive today. I mean, they always say, please no ether. So we don't have ether anymore. But so anesthesia's come a whole very long way.
How much has it changed like in the last decade that you've been practicing?
Not that much.
Really? I feel like you've kind of nailed it down at this point.
I mean, new drugs, new combination of drugs, maybe work a little bit better for for patients. But I mean, it's the same for drugs.
Yeah.
That you're used to.
Mm-hmm.
But I mean, it still gives you anxiety. It's still an anxiety-provoking job for sure. Not all the time, but when you're dealing with someone really, really sick, it's very anxiety provoking. I mean, the whole thing is about the airway, right? People can't breathe, they die. Mm-hmm. So that's basically, and so when COVID was happening, people didn't want to go and intubate these patients because it was very high risk and you'd get COVID, right? So we were the people that they'd call, and we had an intubation team that would go and these huge, like we'd have to gown. I mean, you should have seen these spacesuits that we'd have to go and enter the room.
Holy cow. Well, it'd be hard to actually do anything. Use your hands, I'm sure, if you've got gloves on and all that.
Yeah, well, it was. And we had those like spacesuit things on.
At what point did they stop with all those protocols and get back to normal life?
God, I don't even. Oh, normal life, it took a long time. But remember when nobody was working at that point?
We never stopped.
Y'all didn't?
Mm-mm.
No.
Really?
We were essential, air quotes.
Really?
Mm-hmm.
And people were still wanting to build things during...
Well, for us too. I mean, I was still with Alan at the time, but thankfully the clientele that we had were affluent. And so, in downtimes like that, interest rates are low.
Yeah.
And so I think people that, have money, they see downtimes as a good opportunity. Guys are looking for work. I mean, so it actually ended up being there was like a few weeks of like, what's going on here? Mm-hmm. And then after that, everyone was just on fire building.
Actually, it was probably during COVID that y'all were building my house.
That's what I think. I think it was right around that time too. Yeah.
Yeah, you're right. I guess
it was a really good time for building. Materials shot way up, so that was tricky because lumber packages would go from. I remember we had one house that was $70,000 or something in lumber, and then overnight it was 130.
Yeah,
so there were some logistical issues, and then appliances and garage doors and things. Yeah. But no, everyone was still building, and at the time too, people were freaking out because the costs were so high.
Yeah.
But now look at it today. Anyone who built during that time could probably double their money on whatever they built.
Right. I mean, when I built, it was even lower than, so I really lucked out during that whole thing.
Yeah, you timed it very well.
I know. I didn't mean to, but I did. And I love my house.
I was going to say you should sell it and we'll build you a new one.
I can't afford a new one. Well, maybe with the old I don't know. I love my area and everything. But yeah, so anyway, Eric, we live on a golf course, plays golf all the time. I'm learning to play golf. I'm not good. I'm really not good at very much, to be honest, like sporting wise.
Yeah.
But, I stay active, and I don't even know. I'm not that boring. I have a lot of weird things happen to me, but not having to do with anesthesia. Not having to do with anesthesia. So.
Well.
Yeah.
Thank you so much for coming on. I don't know if there's
You're
anything else we
welcome.
missed, but I feel like we covered the Annie story pretty well.
Yeah, the Annie John story.
Oh, yeah.
Okay.
It's a good one.
Yeah. If you ever need anesthesia,
Don't call her.
don't call me. I'll give you some good names.
There you go.
If you need a surgeon, I will definitely recommend a surgeon.
Okay.
Especially a heart surgeon.
And know that if you happen to hit the potluck and you do get Annie John as your anesthesiologist,
Very good.
you are going to get very drugged up.
Yes. You are. Because guess what?
Dr. Feel Good.
I don't want to hear you talk.
Here you go. On that note, we're signing off.
Thank you, boys.
Thank you for coming on.
Yeah, no problem.
All right, so we ended the podcast and then had a whole side thought that we're going to add back into it. And so talk to us about access on these drugs.
Are you asking for yourself? I'm just kidding.
Maybe. Tell me about access first, and then I'll decide.
So we just kind of got to talking, and anesthesiologists and nurses in the ICU and all, we have crazy access to drugs that can kill people, right? And so when I went to residency, the first thing that my chairman we sat down the whole class. He had a barbecue over at his house. I will never forget it. And we watched a video about addiction in anesthesia. And it is a real thing.
So what do you mean by access? Like you're in the hospital and the drugs are right there and you can just grab them and put in your pocket? I mean, what does that mean
Well,
exactly?
back in the day when I started, when I was training, it was a lot easier to kind of, misplace a fentanyl or, just say you gave the patient fentanyl when you really didn't and you gave it to yourself or whatever. But now it's a whole computerized system, and you have to, if you only use a little bit of the fentanyl, you have to waste the fentanyl with a nurse or whatever. But even still, there's ways people can get around it and, say they gave the patient all the fentanyl. I mean, fentanyl is just a clear substance, right? You put anything clear in a syringe, it's going to look the same unless now they have these ways of testing to make sure that that's actually fentanyl. You'd have to squeeze it into a machine and it would, but rarely do any of the hospitals have that. So there's still ways that if I wanted to get drugs or any provider providing anesthesia, it would not be difficult to do.
So would you just put a saline solution in a needle basically and act like it's fentanyl?
And then save the fentanyl for me and give the patient saline.
Holy cow. So there's been an epidemic, that might be too strong of a word, with anesthesiologists of overdosing and having big drug issues because the access is so easy?
I personally have 2 friends who have died from anesthesia,
Holy cow.
anesthesiologists. And usually, actually 3, one recently, that usually they're not trying to die from it. Obviously, they're just trying to get high from it. But they do too much, and then you just have to realize that, we have Dilaudid, we have propofol, we have morphine, fentanyl, ketamine at our disposal. So if you think about it, it's the one job that you can have those drugs, and it's just too easy. It's too easy to do and to try to get high from it. But same thing with nurses too. And so we have, it's not uncommon to have a death a year, I would say, in a hospital when a nurse is found down in the bathroom because they.
So they're doing it at work. They're just there shooting up. Do they not? How long do these drugs stay in your system? Are they not drug testing doctors and
Great question.
regularly?
Yeah, they're no.
Wow.
That
seems like the easiest way to fix it is
easiest way.
Yeah, just drug test you every time you come in.
I'm always like, why aren't we testing anesthesiologists every month?
So y'all are just never tested?
No.
Holy
They
cow.
said that we can be randomly drug tested. I've never been drug tested since I started my job. Never.
Well, instead of trying to lock up all the drugs, it seems like if they're... I wonder how many of them though are taking them and selling them instead of using... Or is it mostly people using it for themselves, do you think?
I think mostly people using it for themselves. I will... another thing that people do is, the gases of anesthesia. If you just, inhale the gas of anesthesia, it gets you pretty high pretty quickly. I don't know why anybody would do that because you just fall asleep. But a couple of my friends or one of my friends, since, you inhale this stuff, he fell forward and fell asleep and his airway got, occluded and he died that way.
Holy
So,
cow.
not only is it IV drug, it's the gas. It's any way people can get high, they will do it. But I agree. I think we should be drug tested more. I think every medical person should be drug tested more. I don't know why, if someone is found altered or they make a huge mistake in anesthesia or whatever, and we feel like drugs may play a role, then the group can say, hey, we need you to go right now. We've had instances where we say, we need to go get you drug tested right now. So they take them to, but unless there's an offense of some sort, I've never even been tested.
That's crazy.
And I have access to whatever I want.
It'd be so easy for them to do a hair sample every 80 days.
I know. Maybe we should start that.
Yeah.
Yeah. So anyway, start testing everybody. But especially in the anesthesia world, right? And that's really the main place that,
Holding someone's life in your hands, you don't even be getting high at work.
Yeah, but then there's also things that can cross-contaminate, and like poppy seeds can make, did you know that?
Yep.
Yeah,
Make you false positive and all
for
that.
So
Stay away from those bagels.
Stay away from those bagels. But yeah, it's a big problem in anesthesia. I think there are probably more people than you think that I mean, in a huge group of 200 people, there's got to be people that are
Sneaking something.
I would
scary.
think. I know that is scary. I'm too scared to try drugs. I see what they do to people, and they're very they're altering, right? And I don't like to lose control, so I wouldn't be a really good drug addict.
But you're great at giving them, it sounds like.
Yeah, I'm really good at giving them. But
Every time I've had surgery, they lay down. It's like count backwards. I sit up. I'm like, no, I'm gonna fight it. And it is gnarly.
I know. I had one guy say
It goes real quick, but every
Yeah.
time I'm like, whoa, this
I know.
this is real.
One guy was like, anesthesia doesn't work on me. I'm like, really? And he's like, he's like, I'll bet you it does not work. I'll give you, it's never worked. He said, I'll bet you every dollar I've got that it's going to work. And as I was saying that, I just gave him propofol, and he just.
Good night.
So he was betting me that it wouldn't work. But anyway, yeah, it's a big problem. It's not a joke. It's kind of a serious deal. And but now everything's getting more and more controlled. So, you really have to waste it. People have to see you put it into, this special device now that holds all the extra narcotics and stuff. So it's gotten better, but it's not perfect.
Yeah,
I bet the 90s were the Wild West.
Oh, I mean, I'm sure. Yeah. I mean, it's a thing. It's called diversion, drug diversion, and it's a thing in the hospitals. And so people are always like, oh, someone's diverting drugs again, so.
I mean, working teams of two, the person watching you dispose of it, if they're on your side, you know what I mean? Have a little,
Right.
I'm
Right.
just saying. Yeah.
But I mean, basically, it looks like saline. Most of the drugs we have look like saline in a syringe. So it would be very easy to, propofol's white, so that you couldn't really replicate, but other ones you can. So it's a big part of the job that I forgot to mention.
That's scary. I meant to ask you this earlier, but I doubt it. But is there any sort of automation that's coming in that could affect your job or how you do it?
That's a great question. I would think so. I still think there has to be a physical anesthesiologist. Are you talking about like AI stuff?
Yeah, well, I would imagine that someone still has to put the tube down somebody's throat. I mean, that's going to be very hard for anything to take over.
Right,
but then during the process, it sounds like when you're on autopilot, more or less, and you're just watching gauges and you're giving more medicine here and there. It seems like a lot of that could be automated.
I would agree. I mean, I think we're far away from that, but I think there'll probably have to be an anesthesiologist in the building. But, if you can automate, drips, and if the blood pressure goes down, give this, and you can probably just have, I don't know, I can see it maybe happening in the future.
Yeah.
But hopefully after my career's over.
It seems like the reaction time, though, would be a lot quicker if it just knew automatically.
Yeah, I know. I think it's coming, though, for so many other specialties like radiology, unfortunately.
I've heard that AI can read things much faster or better than some doctors can when they're looking.
I mean, I would think they would be able to. I mean, there's just so much that it's going to be able to do. I think that some doctors' specialties might be out of a job.
I'm curious if there's what are those? Sometimes there's people listening that are in school right now, might need to change what they're doing.
I mean, a computer can read an X-ray. It has to, with a bunch of data gathering. I would think it'd be able to read an MRI, X-ray, CT, or whatever better than a human at some point. I'm not saying that it's here yet, but that. And then I also think that, if you, I know AI can't reason, but, if you have so many symptoms of a patient, and you could probably generate an AI like differential diagnosis of what the patient could have, maybe more than a human. I don't know, but I think everything's going to go that way. I don't know if anesthesia will. It'll take a long time, but there's got to be someone giving a drug, fixing a problem, fixing a blood pressure, fixing a heart rate, or whatever.
You see the robot like cramming the tube down your throat, like no, slow down, robot.
Right.
But I do think AI with everything being such digital records now, like you said, you've had 5,000 reps putting people to sleep.
Yeah.
If there's 500 anesthesiologists in the country and all this stuff's digital, AI could file through all of it, memorize it, and pick up on all the patterns. And
Yeah, but there's got to be machines infusing the drugs and the IV fluids. So if you could get that, and then the anesthesiologist, or I don't know. It's gonna be a long time from now.
I just had a thought too. I mean, with the whole drug situation going on, if all the drugs were in a locked container that and AI was dispersing those, it might prevent it actually having to go through a person that could potentially steal them, because it just goes straight from that to the patient.
the AI figures out how to get high.
Right. That rhymes.
On that note, we're going to end this again. Thank you, Annie.
Yeah. Don't do drugs, people.
Unless she gives them to you.
That's right.